Hello, everyone. Today we will be covering Chapter 8, which is the different types of joints of the skeletal system. All right, some roots, prefixes, and suffixes that you'll need to know. Most of these you probably aren't going to be familiar with. Really, the only one that you might know, suture, kind of means sewing. We'll talk about most of these as we go through this lecture. All right, so I mentioned before that anytime bones come together to join together, we call them, joints. But the more proper medical name is an articulation. So, um, you know, your phalanges, your phalangeal joint articulates with your metacarpal. Your metacarpal articulates with with some of your carpals. So basically, an articulation or a joint is just a functional connection between bones, and they're going to bind your skeletal system together, make bone growth possible. We have about 230 joints in the body. Remember, we have about 206 bones in the body. So some bones articulate or join together with multiple bones. Joints obviously make bones able to move when skeletal muscles contract. So skeletal muscles contract enables you to flex your arm, for example. All right, so we have many different types of joints, and we can classify those joints structurally based on what type of tissue binds those bones together. And we have three different types of structural classifications. We have fibrous joints, cartilaginous joints, and synovial joints. Fibrous joints are held together by dense connective tissue. And we'll be breaking each one of these down a lot more. Cartilaginous joints are going to be held together by hyaline cartilage or fibrocartilage. And synovial joints, which we'll talk about later, have more of a complex structure. These are going to be joints that you typically think of like really freely movable joints. Functional classification of joints are joints, how we classify joints based on their degree of movement. So synarthrotic joints are basically immovable joints. So sometimes bones are bound together, but they're not able to be moved. And we'll go through examples of those later on. Amphiarthrotic joints are slightly movable. So your vertebral bodies, your symphysis pubis. So your vertebrae, they're slightly movable. Sometimes, as a kid, you can do a back bend, but they're not freely movable. Your symphysis pubis, that's the area that kind of where your pelvis comes together at the base of your pelvis, and it allows for slight movement. Mostly during childbirth, it will allow baby to pass through birth canal. Diarthrotic joints are freely movable, like your elbow. And diarthrotic joints are typically what we think of when we think of joints. Your shoulder joint, your hip joint, your knee joint, your elbow joint, your finger joints. All of these are freely movable. Most of the time when we think of joints, we don't think of the synarthrotic joints. We don't think of the amphiarthrotic joints. We think of those that help us walk and talk, and those are the ones that are freely movable. But again, we'll go through examples as we progress through this lecture. All right, so fibrous joints. Fibrous joints are the ones that are held together by dense connective tissue. So dense connective tissue, remember, contains collagen fibers. So these are the ones, protein, collagen, highly compact, dense connective tissue, resistant to wear and tear. These are found in bones that are very closely compacted together. And we have three types of fibrous joints. Syndesmosis, suture joints, and gomphotic joints or gomphosis joints. So syndesmosis joints, those are bound by a sheet of dense connective tissue. We also call that an interosseous membrane. So between osseous bones. So between membranes between bones, or a high collagen sheet of dense connective tissue, such as between bone ligaments. So ligaments that are between bones. And you can see the picture here. There's a ligament there that's connecting the bone. There's a membrane here that's connecting that tibia and the fibula. And syndesmosis joints are typically amphiarthrotic. And if we go back to what an amphiarthrotic joint is they're slightly movable. And a good example is, and I'm going to use the radius and ulna because that's what you can see in the picture. So as you rotate your hand or as you pronate your hand, those bones, the radius and ulna, are going to kind of rotate over. They're not freely movable. They're slightly movable. So they're going to be amphiarthrotic. So here under the example, we could say tibia, fibula, or we could say radius, ulna. So example, the intermediate radial ulnar joint is the one that I just showed you. So suture joints are another type of fibrous joint. They're bound by connective tissue, and they are going to be immovable joints. They are synarthrotic joints. So we see these in the skull as the skull grows, as the cranium grows. Eventually, these sutures will be closed. They're going to kind of harden, and those sutures are going to kind of become immovable. And when baby is born, what we see is we have these things called fontanelles. Babies actually kind of have holes in their head. There's an anterior fontanelle and a posterior fontanelle, and you can actually kind of push your finger down in baby's head and you can essentially touch the brain tissue. Don't recommend it, but these fontanelles, one closes really early on in life and one closes about 18 months in life. And it just allows for baby's brain to grow. So when baby is born, these suture joints are not fully closed up. They are not synarthrotic joints. They are actually slightly movable when baby is born because we have to allow for baby's head to grow. And then as baby matures a little bit, and those fontanelles close up, and once baby's head is grown, then those suture joints close up and they kind of solidify, and then they become synarthrotic joints because now they are immovable joints. Gomphotic joint or gomphosis is a synarthrotic joint. It is an immovable joint. Really, the only place that we see this is in your teeth, where that tooth kind of sits in that socket, and it's bound together by this periodontal ligament. You can see the periodontal ligament there. Remember that those suture joints are held together by that ligament. So your teeth are really immovable. However, they can be moved, by braces or Invisalign, something like that. So suture joints, connective tissue. You can see the connective tissue there. All right, so kind of go back to what I was talking about with the baby's brain growing. So we have a condition called craniostenosis. And in craniostenosis, the bones of the skull fuse together at the sutures prematurely, causing the brain to grow abnormally. Why would this cause abnormal brain growth? So remember that I was talking about normally when baby's born, those sutures they aren't synarthrotic joints. They are amphiarthrotic joints. They're slightly movable when baby is born to allow for brain growth. And then at some point during development, they become synarthrotic joints. But in craniostenosis, baby is born, or those sutures fuse together prematurely. So why would this cause abnormal brain growth? All right, so sutures are large gaps between bones that are filled with synovial fluid. This synovial fluid allows for the brain to expand into spaces. Ossification of the sutures would prevent the expansion of the brain. So we haven't talked about, we talked a little bit about synovial fluid when we talked about the visceral pericardium and the parietal pericardium, the visceral peritoneum and the parietal peritoneum, way back several chapters ago. But we have not talked about the synovial fluid in conjunction with the brain. There is no synovial fluid in sutures. So we're going to throw this one out. All right, the sutures are amphiarthrotic and slightly movable during brain growth, so the plates of the skull can easily move to suit any direction of brain growth. Fusion at the sutures will prevent this free movement. Okay, so that sounds like a viable answer. Causes abnormal brain growth. Okay, so we'll keep that one for now. All right, the sutures are synarthrotic. Let's go back to our definition. Synarthrotic is immovable and do not move, only allowing expansion from within as brain grows to fill the brain case. Fusion at the sutures will prevent this expansion. So from a textbook definition, this is correct. However, only allowing expansion within as the brain grows to fill the brain case. So when that's going to be our disqualification for this answer. So the brain is encased in the skull, and that's why we have sutures to allow for brain growth. The sutures are the head grows and the brain grows. If the sutures are synarthrotic, that means the brain can't expand outward. The brain can only expand inward, inside the head. And in that case, there's only one place that the brain can go, and that's downward. And if you've ever looked at a picture of the skull, underneath the skull, we have this hole called the foramen magnum. And so the brain would actually go through the foramen magnum and cause what's called a herniation of the brain. And that's immediate brain death. So we're going to throw out C. And we'll talk about herniation of the brain. I believe we might have talked about it in one of the previous chapters. I'm not sure. All right, so because the sutures contain ligaments, all right, do sutures contain ligaments? Okay, so sutural ligaments, yes, it's a type of connective tissue. Oh, so because the sutures contain ligaments, yes, blows to the skull can be absorbed by plate movement. Removal of the sutures will cause any slight blow to damage the brain. All right, this has nothing to do with abnormal brain growth, sutures prematurely causing the brain to grow abnormally. So we're going to throw this one out. So this has nothing to do with the question. So we're going to go with answer B. So remember, normally a child's skull bones will fuse together, forming the sutures around 2 years of age. At this point, the sutures, remember the sutures used to be amphiarthrotic, meaning that it was slightly movable, but around 2 years of age, the sutures become a synarthrotic joint, meaning that it's immovable or immobile. And then now the plates of the skull are not movable. Prior to that, the plates of the skull used to be movable. So in craniostenosis, the early fusion at the sutures will prevent any movement of those skull plates. The frontal bone, parietal bone, occipital bone, temporal bone, so that the brain cannot grow. All right, so those are the 3 types of fibrous joints: syndesmosis, suture joints, gomphosis joints. Moving on to cartilaginous joints. We have 2 types. Remember that cartilaginous joints, easy to remember: hyaline cartilage, fibrocartilage. We have 2 types of cartilaginous joints. We have synchondrosis and symphysis joints. Synchondrosis joints are basically hyaline cartilage that bind those together. They are synarthrotic, and their function is basically to allow for bone growth. Says here some are temporary. Remember that epiphyseal plate or your growth plate allows for bone growth between that epiphysis and diaphysis. And then at some point that ossification converts it to a synostotic joint. And some are going to be permanent, such as between the manubrium and that first rib. So this is your manubrium, and this is that first rib. And we'll see this in long bones of children. And then eventually, we learned last chapter that cartilage will eventually get converted over into osseous tissue or bone tissue. So we see a lot of synchondrotic or synchondrosis here between those, between your ribs and your sternum. The other type of cartilaginous joints, remember, hyaline cartilage, fibrocartilage, is the symphysis joint. Fibrocartilage. We can see those pads of fibrocartilage. That's what your intervertebral discs are made up of. Your symphysis pubis, remember I talked about that earlier, allows for expansion for childbirth. They are going to be amphiarthrotic, limited movement. You can't twist your spine all the way around. Your hip bone, they can't fully come apart. They're amphiarthrotic, limited movement. The other place we'll see symphysis joints is on that, remember those articular surfaces of the I can't talk, epiphyses. But that's actually hyaline cartilage, not fibrocartilage. All right, so suppose the symphysis pubis or pubic symphysis, doesn't matter how you say it, did not exist in the pelvic girdle and the two pubic bones were fused in the middle. Which of the following best describes the way the region would be affected if this joint was removed? So basically what we're saying is this area right here did not have that pad of fibrocartilage, and that these two bones are fused together. That's kind of what this question is asking. So the femurs would grind the inside of the acetabulum, causing pain because of a lack of cartilage. So basically the femur comes in here, and the femur is like a ball and socket joint. So the ball of the femur actually comes in here, and your femur kind of goes down this way. So in answer A, the femur has nothing to do with this pad of cartilage right here. So we're going to cross off A. The pelvic girdle would be highly unstable because the pubic symphysis adds stability and rigidity. Well, nothing here says stability and rigidity, and actually, it's an amphiarthrotic joint, so it allows for limited movement, so it's not rigid. So we're going to get rid of answer B. Childbirth would have a high mortality risk because the pelvic girdle would be rigid and unmoving. So that sounds like it could be a good answer, because remember that I said this joint allows for expansion of the pelvic girdle during childbirth. Allows for baby's head, and it actually kind of tilts the pelvis a little bit so that child's head or baby's head can actually pass through the pelvic girdle more easily. So that's a viable answer. The vertebral column would not be able to extend because of the rigidity of the pelvis. So we look at our spinal column. Our spinal column actually, if we do our pelvis this way, the spinal column actually comes down here, has really nothing to do with this pad of fibrocartilage right here. So we're going to throw that one out. Has nothing to do with it. So C is going to be our answer. All right, synovial joints. So synovial joints, like I said, that's going to be most of the joints that we think of are joints. Your elbow, arms, fingers, anything that's really freely movable. And the good thing about synovial joints is that all synovial joints are diarthrotic joints. So if we go back to up here, all synovial joints are diarthrotic joints. So this is going to be an easy one to remember. All synovial joints are diarthrotic joints. They're going to have a little bit more complex structure than fibrous joints, cartilaginous joints. We'll briefly look at the knee joint. It's going to be the largest, most complex synovial joint out there. We're really not going to harp on it too much in the next slide. Man. All right, so remember that. So this is a general structure of a synovial joint. Not all synovial joints have this type of structure, but I'm including it in here because this is more of like the knee joint. Remember that we have that articular cartilage that covers the epiphyses of the long bones. And then it's surrounded in this synovial fluid. And in that synovial fluid, we have a bunch of oxygen and nutrients that's going to supply that joint with everything that it needs to continue to grow and thrive. And we have this thing called a joint capsule. And that's how these bones are going to be held together. We have those two layers, almost like that parietal layer and visceral layer, but we don't call it a parietal layer and a visceral layer. But we still have that synovial fluid that nourishes that joint. We have that outer layer, which is going to be composed of ligaments. Remember, ligaments connect bone to bone, tendons connect muscle to bone. And we have an inner layer, and that's where we're going to see that synovial membrane that secretes the synovial fluid. We also have a bunch of blood vessels, and that blood vessels, remember blood vessels typically are going to provide all of the nutrients, oxygen to that articular cartilage, and that's contained within this joint capsule. And again, those ligaments bind those bones together. Ligaments connect bone to bone, muscles connect, or tendons connect muscle to bone. We have that synovial cavity. We have a bunch of sensory receptors. Which is why if you blow out your knee, it's very painful. In some synovial joints, we have a meniscus or a menisci, plural. Basically, it's a fibrocartilage disc that's going to divide a joint into two different compartments. The knee has a meniscus. We also find that some joints have a bursa. Basically, it's a fluid-filled sac containing that synovial fluid. Again, only present in some joints, around 160 joints in the body. So if we take a look at the knee, this would be our femur, and this would be our tibia down here. So you can see that that joint cavity, remember that articular cartilage covers the ends of the long bone. You can see that synovial membrane. Those are going to be our ligaments with that fibrous layer. We can have a bursa. The knee joint has a bursa. There's your patella. That's also your kneecap. Another bursa. Some have some fat with it. There's a meniscus there. So again, highly complex. Like I said, we're not going to be going over this too much. You'll do that in a kinesiology class if you take that. But just know that in the knee joint, it's going to be the femur and the tibia. The fibula is not in the knee joint. Fibula is a little bit shorter than the tibia. All right, so remember that synovial joints are diarthrotic joints. All synovial joints are diarthrotic joints. And we have 6 types of synovial joints. And I mentioned ball and socket joint when I talked about the femur going into the acetabulum. And so ball and socket, we also call it a spheroidal joint. No one says spheroidal joint. Everyone calls it a ball and socket joint. It's going to produce the widest range of motion. Multi-axial, that's more three-dimensional. Plus rotational. So if you look at, your hip and shoulder, those are going to be your 2 ball and socket joints. You can move your shoulder up and down, left and right, and you can rotate your shoulder in a circular motion. So multi-axial. one plane, two plane, three planes in a circular motion. A condylar joint, also called an ellipsoidal joint. Again, rarely you're going to see ellipsoidal joint. Basically, this is a two-dimensional joint, no rotation. Basically, a back and forth motion or a side-to-side motion. You will see this more in this joint right here between your metacarpal, which is the top of your hand, and your phalanges, or your metacarpals, which is the top of your foot and your toes. So this joint right here. And it just allows your hand or your fingers to bend up and down. All right, a plane joint or a planar joint, also called a gliding joint. Sometimes you'll hear the term gliding joint. Again, back and forth, sometimes twisting, non-axial movement. Most of your wrist and ankle joints. So a lot of your carpal joints and your tarsal joints. So let's just put those in: carpal and ankle, tarsal joints. All right. Hinge joint. Basically convex into a concave surface. Uniaxial movement. So basically you can only move this in one plane. No rotation, one movement only. So think of the elbow. Only flexion, only extension. You can't move your elbow kind of left and right. Up and down, or one plane only. And then between your phalanges, you can't move your fingers left and right, only up and down. All right, the fifth joint, pivot joint, also called a trochoid joint. You'll never hear trochoid joint. Uniaxial movement, basically uniaxial movement. This one is rotation only. And if you remember in lab, we talked about the atlas and the axis. So your C1 and C2. So this will be able to move your head to left and right to say no. So that's your C1, C2. Your saddle joint, also called a cellar joint. You'll never hear cellar joint. Again, concave, convex surfaces, biaxial movement, so two planes. So this is between your carpal and your metacarpal of your thumb. So that would be this joint down here, right there, between your trapezium and that first metacarpal. All right, so here's, I just put together a summary slide for you to kind of go over the three different types of fibrous joints, the two different types of cartilaginous joints, and the synovial joints. So remember, all synovial joints are diarthrotic joints. You're going to have to know this slide kind of inside and out. Cartilaginous joints can be either a synchondrotic or a symphysis joints. Synchondrosis joints are synarthrotic. Symphysis joints are amphiarthrotic. Fibrous joints, we have three classifications: syndesmosis, suture, gomphosis. Syndesmosis are amphiarthrotic. Suture joints are synarthrotic. And gomphosis joints are synarthrotic. Remember, synarthrotic is immovable, amphiarthrotic slightly movable, diarthrotic are freely movable. Again, know this slide. All right, for your synovial joints, You're going to have to know the 6 types of synovial joints. Don't worry about this column, but you will have to know which 2 joints provide rotational movement. So your ball and socket and your pivot joints both provide rotational movement. And you're going to have to know examples of each type of joint. So your ball and socket joint, I said, was your shoulder and your hip joint. But now we have to talk in medical terms or A&P terms. So your shoulder joint is actually your glenohumeral joint. And if you remember from lab, your gleno, we have a glenoid fossa in your scapula, and then your humerus goes into that glenoid fossa. And then in your hip, we have an acetabulum, and then your femur goes into that acetabulum. For condylar joints, we have that metacarpal and your phalanges. So your finger and your metacarpals. For planar joints, your radius and your carpals. Your talus, and so just kind of go through these and figure out what these all mean. Some of these you can figure out, your carpals and your metacarpals. But if you don't know where your proximal radial ulnar joint is, you might want to figure it out. What does the word proximal mean? We've gone over this a few times already. All right, so suppose all synarthrotic joints were fused in an individual. Which of the following would be true? All right, so what is a synarthrotic joint? Synarthrotic joints are immovable. All right, so we have if all immovable joints were removed. IMMOVABLE. So braces would not work to straighten the person's teeth because their teeth would not move. So is teeth a synarthrotic joint? That's what we need to know. We go back way up here. Teeth is a gomphotic joint. It is a synarthrotic joint. So that one is a viable answer. The person would not be able to bend forward because their vertebral column would be fused. Well, we already know that the vertebral column is slightly movable, so it's not a synarthrotic joint. It's slightly movable, so it's an amphiarthrotic joint. So we can go ahead and cross that one off. The person would not be able to flex their fingers and grasp objects. So we already know that the fingers are not a synarthrotic joint. It's a diarthrotic joint. Head turning would be impossible. So we already know we can turn our head. So that's not a synarthrotic joint. That's actually a diarthrotic joint. So we can cross off that. So we're going to go with A because this is the only joint that is a synarthrotic joint to start out. All right, a patient has a condition in which collagen fibers are incorrectly manufactured and are non-functional. What type of joints are going to be most heavily affected? Now, first we have to go back to, collagen fibers. What joints are made up of collagen? So, syndesmosis, high collagen sheet. So syndesmosis, we have syndesmosis so far. Cartilaginous joints are hyaline cartilage or fibrocartilage. So no, no. Hyaline cartilage, fibrocartilage, cartilaginous. All right, so we're looking for syndesmosis joints. So let's go back to our chart. Syndesmosis. So they're a type of fibrous joint. So we have syndesmosis. And then contains collagen fibers. Here, I guess I didn't go back enough. Collagen fibers, 3 types of fibrous joints: syndesmosis, suture, gomphosis. That's what we're looking for. Syndesmosis, suture, gomphosis. So answer D, collagen fibers make up fibrous joints. All right, so types of movements. We know skeletal muscles produce movement at synovial joints. We have what's called an origin and an insertion. Every muscle, you know, we have 206 bones in the body. We have a lot of different muscles in the body. And when we get to, anyway, so each muscle has an origin and an insertion. So the example here is the biceps. It's the biceps brachii, and bi means 2. So that means that the origin has, that the biceps has 2 origins, and the biceps actually has 2 origins on the scapula and 1 insertion on the radius. So when you contract a muscle, what happens is that muscle pulls the insertion towards the origin. So when you contract and remember the insertion is on the radius, the origin is on the scapula. So when you contract your biceps, you're pulling your radius towards your scapula. So when I went through biology and A&P, we actually had to memorize the origins and insertions of the muscles. So just be glad you do not have to. Here's an example, the biceps brachii. We have 2 origins. There's a long head and a short head of the biceps. The long head originates on the supraglenoid tubercle of the scapula, the short head on the coracoid process of the scapula, inserts on the radial tuberosity of the radius. So we pull that when the biceps brachii muscle contracts, we're actually pulling the insertion up towards the origin. All right, so remember, we have a bunch of different definitions that you're going to have to memorize. You are going to have to know the next 3 slides. Flexion, bending of a body part at a joint. You flex your arms. You bend your neck. You bend your leg at the knee. You're bringing your heel closer to your butt. Extension. You're straightening that body part. You're moving your arm forward so that it's in front of your body. Hyperextension. You're extending that arm past the normal anatomical position. Typically, sometimes this can cause tissue damage or ligament tears. Lateral flexion is bending towards the side laterally. Remember, lateral means towards the side. Abduction versus adduction. Abduction is moving a body part away from midline. Adduction is moving a body part towards the midline. So if my arms are extended out here, my arms are abducted. And if I move my arms towards here, I am adducting, ADD. The way I remember this is if my arms are out here, I am adding towards the midline. I'm ADD-ing. So abduction away, adding towards the midline. Away from midline, adding towards the midline. All right, more definitions. Dorsiflexion. Basically, you're flexing your feet, so you're bringing your toes or your foot closer to your shin. Plantar flexion. Basically, you're pointing your toes. You're moving your toes or your foot away from your shin. Circumduction. You're moving your body part in a circular motion. Rotation. It's very similar to circumduction, but like, for example, you're turning your head to look at something over your shoulder. Circumduction. Medial rotation versus lateral rotation. Medial rotation is moving a limb so that anterior surface moves towards the midline. So here, think of like abduction versus adduction. So here you are moving your limb towards the midline. Medial rotation versus lateral rotation. Medial rotation, lateral rotation. Medial, lateral, medial, lateral. Supination versus pronation. Remember, we have to go back to anatomical position. Remember anatomical position, standing upright, arms down to your side, palms facing forward. So this would be supine, where your palms are face up. Pronation is your palms are facing down. Supine, pronation. For those of you who are going into nursing or in the medical field, if you're laying on your back, you are supine. If you're laying on your stomach, you are laying in the prone position. Your patient is pronated. Again, you have to know all of these definitions. Again, more definitions you have to know. Inversion, turning your foot so that the plantar surface faces midline. You're turning your foot inward. Eversion, you're turning your foot outward away from midline so that the bottom of your foot faces outward. Protraction, moving your body part forward, so sticking out your chin. Retraction, moving a body part backward, so like tucking in your chin or moving your chin closer to your spine. Elevation, raising a body part, so like raising your shoulders up. Depression, lowering a body part, pushing your shoulders down. Again, you have to know all of these definitions. All right, so suppose the ball and socket joint of the hip was replaced with a pivot joint, and in which the femur is directly placed in the acetabulum. What movements are now the only movements possible? So now we have to go back to our chart to see what a pivot joint can do. So a pivot joint is uniaxial and it can only provide rotation. So rotation is going to be our answer. All right, so we've already talked about synovial joints a little bit, and we've already said that the knee is the largest and most complex. Other examples, shoulder, elbow, jaw, hip. We're really not going to rehash synovial joints, but we will talk a little bit about the jaw. Your jaw joint, it's called the temporomandibular joint, abbreviated TMJ. Basically, it's a modified hinge joint. Remember, we talked about a hinge joint. Between that mandibular condyle of the mandible, that's your lower jawbone, and the mandibular fossa of the temporal bone. So it goes between your lower jawbone and your temporal bone. And it also has a joint capsule. It has an articular disc made up of fibrocartilage, and it separates that synovial cavity into two portions. There's two ligaments that are involved: the sphenomandibular ligament and a lateral ligament called the temporomandibular ligament. But basically, this is the only movable ligament or only movable joint in the skull. And you know that we can, since it's our lower jawbone, our mandible, we can chew, we can move our jaw left and right, so forward, side to side movements, and we use our mandible for biting food, grinding food. So here's just a picture of that. Remember, it can be a hinge joint, also a gliding joint. We have that lateral ligament, that sphenomandibular ligament. That lateral ligament, remember, it's also called that temporomandibular ligament. We have that mandibular condyle right there, and that joint is that mandibular condyle that goes into that mandibular fossa. Fossa just means kind of like a hole. So that mandibular condyle goes into that mandibular fossa of the temporal bone. So if you've ever heard of, I have temporomandibular joint syndrome or TMJ, basically, and this is actually what your dentists are now checking for this. They'll feel right here, open, close, open, close, open, close. They're feeling for like a clicking sound, or if you have any pain, your symptoms, pain in your face, head, back, front of the ears, ringing in the ears, insomnia, temperature sensitivity, dizziness. Basically, your cause is misaligned jaw if you're grinding or clenching your teeth. Actually, sitting or standing in one place for many hours can cause TMJ. And what happens is that articulation, or that you have an articulation problem, so that between that mandibular condyle and that mandibular fossa, that temporal bone kind of becomes misaligned. And basically, you're just going to do some physical therapy. You can have some corticosteroids. You can use ice packs, relaxation techniques, try eating soft foods. Sometimes you actually have to have surgery to repair that joint. Um, but it can be very painful to have TMJ. All right, shoulder joint. Remember that shoulder joint is a ball and socket joint. We have that glenoid fossa and that humeral or that glenoid cavity, that glenoid fossa, that scapula, and the head of the humerus fits into that glenoid cavity. So there's that glenoid cavity and the of the scapula, and that head of the humerus or that ball of the humerus kind of fits into that glenoid cavity. It's a very loose joint capsule, and we have a lot of bursa or bursae in there. It's a multi-axial joint, remember. So that shoulder joint, that ball and socket joint, lots of rotation, three-dimensional movement plus rotation. There are several different ligaments of this joint capsule or of this joint, and you are going to have to memorize two of them. The easy one is the glenohumeral ligament. You should be able to recognize gleno because of that glenoid cavity or that glenoid fossa, and then humerus. But we also have this coracohumeral ligament. You should be able to recognize humeral because of that humerus, but that coraco, that's that up here is that we have that, remember that coracoid process of that scapula. So that's what that coraco is referring to. So we have that coracohumeral ligament. So those are the two that you're going to have to memorize for the quiz and exam purposes. And we also have a transverse humeral ligament. You don't have to memorize that one for the exam. The elbow joint contains two articulations. One is actually a hinge joint between the trochlea of the humerus and the trochlear notch of the ulna. So humerus and ulna. And if you remember, so the humerus and the ulna. So there's the trochlea of the humerus. And the trochlear notch is not labeled up here. All right. So remember that hinge joint is just flexion extension only. We also have a plane joint or that gliding joint between the humerus or the capitulum of the humerus and that head or the fovea on the head of the radius. So that elbow joint actually has two articulations. So there's your radius, we have the humerus, and we have that, again, it's not, there's your radius. It's not labeled, but we go over that in lab. Some of the major ligaments of the elbow joint that you have to know, that radial collateral ligament, the ulnar collateral ligament. The good thing about the elbow joint is that anytime you see collateral, think of the elbow joint. So your ulnar collateral ligament, radial collateral ligament, the annular ligament, there's your annular ligament right there. All right, your hip joint, ball and socket joint. Between that femur, the top of the femur, and that acetabulum of the hip bone. It is reinforced by a bunch of ligaments. It produces it has less freedom of movement than the shoulder joint. And we're not going to memorize any of the ligaments for the hip joint. So out of there. So why does the hip joint have less freedom of movement than the shoulder joint? So the articulating parts of the hip are closer together than those of the shoulder. Okay, maybe. The hip has less synovial fluid than the shoulder. Okay, so there's the hip. So the degree of synovial fluid does not dictate freedom of movement. So we're going to get rid of that. Basically, the degree of movement goes back to I'll give you that answer later on. So the hip joint capsule is less elastic than the shoulder. So elasticity refers to elastic fibers. Remember that rubber band is made up of elastic connective tissue. So none of our joints have elastic fibers. The joint capsule of the hip is surrounded by muscles and the shoulder is not. Well, we know that's not the case. So A is going to be our right answer. The articulating parts of the hips are closer together than those of the shoulder. So what I was getting ready to say is that the degree of movement is dictated by how many muscles and ligaments and tendons and stuff is surrounding that joint capsule. And if we look at the hip has a bunch of ligaments and tendons and stuff surrounding the hip joint compared to the shoulder. So we actually have more degree of movement in the shoulder than the hip. So A is going to be our right answer. The articulating parts of the hip are closer together than those of the shoulder. And if we look at the shoulder, that head of the humerus goes in that glenoid cavity, but that glenoid cavity doesn't really surround the head of the humerus all that much. But if we look at the ball and socket joint of the hip, that femur, the head of the femur goes into that acetabulum, and that acetabulum actually surrounds that joint cavity surrounds more of the head of the femur than the shoulder joint does. So that's another reason why A is the right answer. All right, so we've talked about the knee joint before. Largest, most complex. Knee joint consists of 3 bones. We talked about the femur, the medial lateral condyles of the distal end of the femur. We went over this in lab. Tibia, medial and lateral condyles of the proximal end of the tibia, and then the patella. Patella is your kneecap, articulates with the anterior surface of the femur. There's your patella right there. Has lots of tendons and ligaments. Ligaments, bone to bone, tendons, muscle to bone. Lots of bursa, lots of fat pads. The meniscus separates, or menisci, because the knee has lots of a couple different menisci in there, separates that femur from the tibia. Remember, the fibula is shorter than the tibia, so the fibula is not present in that joint capsule of the knee joint. So the knee joint is a modified hinge joint between that femur and that tibia. Um, and then if we look at the femur and patella, it's actually a plain joint. And we only do flexion and extension of that knee joint. However, when that knee is flexed, we can see some rotation. All right, some ligaments of the knee joint. A lot of times we just abbreviate these. So within the knee joint, you can have an oblique popliteal ligament. So anytime you, and a lot of times, as you've seen before, we name them based on what they connect. So the popliteal, or the area that they are in. So the popliteal region is the region kind of behind the knee. So the oblique kind of runs diagonal. So your oblique popliteal region, or your oblique popliteal ligament, runs kind of diagonal. The arcuate popliteal ligament, the tibial collateral ligament, sometimes abbreviated as the MCL, your fibular lateral ligament, LCL, your ACL, is your anterior cruciate ligament, your PCL, posterior cruciate ligament. A lot of sports injuries happen with the ACL, the MCL, and the LCL if you tear one of those. All right, so a professional wrestler ends a match early due to severe pain and loss of function in their lower arm and hand. So lower arm and hand. Upon examination, a major tear is discovered in one of the ligaments of the elbow. So basically, we're looking at the elbow. Which of the following could be a torn ligament? All right, so oblique popliteal. So popliteal is the knee. Ulnar collateral ligament, transverse humeral ligament, coracohumeral ligament. All right, so coracohumeral ligament. So let's go back and figure out where that one was. Whoops. Coracohumeral ligament, that's in your shoulder. So we're looking for the elbow. So coracohumeral ligament, we're going to throw out. This one's in the knee. This one's in the shoulder. Transverse humeral ligament. Transverse humeral ligament is in the shoulder. So we're going to throw out that one. Ulnar collateral ligament is in the elbow. So we're going to go with A as our answer. And remember that I said anytime you see collateral, kind of think of the elbow. And we have several different collateral ligaments that are elsewhere in the body, but we did not go over that. You're not going to have to memorize those. So for purposes of your quiz and exam, anytime you see collateral, that's going to be the elbow. All right, so types of disorders of the joints. Typically, anytime you have a joint disorder, it's going to be because of either trauma, overuse, infection, an immune system issue, or just degeneration and of that joint. And we can diagnose those injuries with this procedure called an arthroscopy. And an arthroscopy is basically where we stick a needle in that joint and a camera. And we can look inside that joint to see what's going on. And we can actually withdraw fluid from that joint to look for, like a bacterial infection, to withdraw that synovial fluid to see if there's, pus inside. Remember that synovial fluid should be kind of like consistency of water. It really should look like water. So it shouldn't have any pus, or it shouldn't be yellow. It shouldn't be gunky. All right, so dislocation. In medical terms, that's called disarticulation. Basically, you've popped a joint out of socket. Very common in your shoulders, knees, fingers, your jaw. Sometimes you can pop your shoulder back into socket. You've seen people kind of just, pop their finger back into the socket. A sprain is seen typically when you overstretch or you've hyperextended that joint. And you can see sometimes that torn ligament. Or you can tear a ligament with a sprain, but you don't always have to. And sometimes you can dislocate a bone when you sprain a joint, but not always. A torn ligament typically results from twisting or hyperextending a joint. You've lifted too much, lifted a heavy object, or you've fallen. Bursitis. Itis means inflammation of, so inflammation of the bursa, typically because of overuse or stress. This is just a picture of a dislocation. That's the head of your humerus, which actually should be up here in that glenoid cavity. So what we would do is we just kind of put it back there. Sometimes it requires anesthesia. We would just give you a little bit of propofol, which would kind of knock you out for a few seconds while we just kind of put that bone back where it should be. All right, so arthritis is, remember, itis means inflammation of. So arthritis is where you have inflammation, swelling, and pain within a joint. We have different types of arthritis. Rheumatoid arthritis is actually an autoimmune disease. Autoimmune just means the body is attacking itself. In this case, the body thinks that the synovial membrane is a foreign object in the body, and the body's attacking that synovial membrane. And in this case, the synovial membrane becomes inflamed and becomes thickened. And we would treat this with steroids and immunosuppressants to try and decrease the body's immune system so that the body stops attacking itself. Osteoarthritis. It's the most common type of arthritis. Basically, it's a degenerative disease that occurs as a person gets older. It's damage to the articular cartilage. Remember, that's what surrounds the ends of the epiphyses. We also have Lyme arthritis. It's caused by Lyme disease. Lyme disease, you get bit by a tick, and the tick has this bacteria in them called Borrelia burgdorferi. Burgdorferi. and it's very easily identifiable because you have this nice, we call it a bullseye appearance. I actually had Lyme disease once. I got bit by a tick. Typically, the where you get bit is not where the site of infection is. I actually got bit by a tick in my groin area, but my bullseye showed up on my foot. And basically, you take 21 days of antibiotics and you're good to go. But left untreated, this Lyme disease can really cause havoc in your body, and it can be a lifelong debilitating disease. And one of my first patients in nursing school had undetected Lyme disease and was pretty much bedridden for the rest of her life. And it was a very sad case. All right, so osteoarthritis. So here's remember, osteoarthritis is the normal, not normal, but a degenerative disease of the articular cartilage, what's at the ends of the epiphyses. And here it's just kind of degenerating or breaking down. All right, so a patient is experiencing joint pain and inflammation. They undergo an arthrocentesis. We're pulling out some fluid. We stick the needle in that joint cavity, an arthrocentesis. We pull out some of that fluid. Their physician discovers cloudy, pus-filled synovial fluid. Which of these conditions is most likely occurring? Gout, bacterial joint infection, osteoarthritis, or sprain? So remember that I said your synovial fluid should be water consistency. It shouldn't be cloudy. It shouldn't be foul smelling. It shouldn't look like pus. It shouldn't be yellow. So if you don't know, this is actually an indication, cloudy, pus-filled. Think of, what happens when you have an infection. So, a bacterial joint infection is going to be our answer. Gout, you'll learn later on is we'll see this a lot, and you'll see this a lot in your toes, and it's a buildup of uric acid crystals, most commonly seen in your toes or your feet. So we'll get rid of gout. Osteoarthritis, remember that's the degenerative condition of your articular cartilage. And then a sprain, due to hyperextension. So bacterial joint infection will cause a cloudy synovial fluid, looks pus-filled. Bacterial infection, just take some antibiotics, you should be good. All right, so replacing joints. We can replace knees, we can replace hips, we can replace a lot of different joints. Just really the two things that you need to know for this. If we're replacing small joints, we're going to use either silicone polymers or ceramics as the material used for small joints. If we're replacing large joints, we're going to use steel and titanium. So we're going to use metals for large joints. Hip joints are the most common joints, followed by knee joints would be the next common. If you ever get the chance to watch one of these surgeries, they're actually very cool to watch. You're actually, everyone has to be gowned up in this very special garb because you don't want these joints to become infected. An infected joint costs the hospital a lot of money, and also the patient a lot of agony, pain, and the process of repeating the surgery. it's just not good for a replaced joint to become infected. So here we're actually replacing a knee. So there's your femur and your tibia. So for your knee, remember we're doing large joints, so we're going to use steel or titanium. So we're going to shave off the end of the femur, and we're actually going to kind of put a cap on the femur. We're going to kind of drill into the tibia, and we're going to put this usually in the tibia and the femur. We're going to use titanium, and we're going to actually kind of hammer in this titanium part into the femur and to replace that joint. All right, so lifespan changes. So as you get older, our collagen changes. That collagen structure changes. And we have joint stiffness. You get out of bed and you're like, oh my God, my back hurts. Many people develop arthritis as they age. Typically, your fibrous joints are the first ones that change. However, down here, exercise and activity can keep joints functioning longer. As you keep that blood flowing, you keep supplying that joint with nourishment. So definitely don't become a couch potato. That cartilage in those synchondroses joints stiffens. Synchondroses joints stiffens. The cartilage. All right, your ligaments are going to lose elasticity. Remember, ligaments connect bone to bone. So, for those of you who could do the splits as a kid, now you can't do the splits anymore. You can't run as fast. You're not as flexible as you once were. Changes in your symphysis joints of the vertebral column. You lose your flexibility. You decrease in height. I mentioned, I believe last chapter, that you're going to lose about 1 inch to 1.5 inches in your height. And that's going to be because your intervertebral discs lose water. Your synovial joints. Remember, all of your diarthrotic joints lose some of your function because the capillary supply diminishes. And if you do become a couch potato, now that because you are not using those joints, you don't have that good blood supply or that good nutrient supply anymore to those joints and ligaments. So therefore, the ligaments are going to lose elasticity, which actually speeds up stiffening. So exercise, activity, even if it's, walking 5 minutes a day, anything that you can do activity-wise or exercise-wise can help keep your joints functioning longer. All right, so a person works an office job, so they sit 10 hours a day, then they go home, they sit, they never exercise, they don't get up, so they are a couch potato. Their joints begin to feel stiff and painful. So what is happening? So being stuck in the same position for long periods of time causes the ligaments to physically decay, stiffening the joints. Okay, that kind of sounds like a viable answer, so we'll keep it for now. Disuse of the joints causes ossification of the fibrocartilage, creating arthritic joints. By about age 25, your joints are already ossified. Actually, let me put an S there. So no, our joints are already ossified, so they can't ossify anymore. Lack of movement results in reduced blood flow in the vessels of the synovial membrane, reducing nutrient supply to the ligaments, which loses elasticity. That sounds like a good answer. We'll keep that one for now. Lack of movement causes the synovial membrane to stop producing synovial fluid, which then increases friction upon movement of the joints. So we won't actually stop producing synovial fluid. We still produce synovial fluid, but so we'll get rid of that answer. So we're down between A and C. So being stuck in the same position causes the ligaments to physically decay. So they don't actually physically decay. What will happen is what answer C says. Reduced blood flow, loss of elasticity. So we're going to go with answer C. All right, so Connie recently celebrated her 45th birthday. She feels okay most of the day, but in the morning, for about a half hour after she gets out of bed, all of her joints feel stiff. What is the likely cause for her stiffness? A torn ligament, changes in collagen structure, a sprained muscle, or damage to the nerve. So basically, let's go back up here. Joint stiffness is an early sign of aging. Changes in collagen structure of the joint. Changes in collagen structure of the joint. Nowhere in the question does it say she has a torn ligament or she's sprained or she has damage to the nerve supply or the nerve. She's getting old. She has changes in her collagen structure. Once you become older, you're going to feel this. I promise you. So change in collagen structure is why she feels stiff in the morning. All right, so that is all I have for you for Chapter 8. Please let me know, Chapter 8. So please let me know if you have any questions, and I will see you next chapter. Take care.